Welcome, welcome, welcome. It is that time, it is that place, that day. It is Ask Dr. Geier Live, wherever you're watching. I hope you're making today your masterpiece. It's the end of the day, what can I say? Very, very excited to be here and very excited that you are here to join me. This is that show where I answer your orthopedic injury questions, your potential surgery or rehab questions, your regenerative medicine questions. Leave those in the chat if you're watching on YouTube. Do not leave those in the comments, leave those in the chat. My name is Dr. David Geier, triple board certified orthopedic surgeon, sports medicine specialist, and anti-aging and regenerative medicine expert. I help athletes and active people feel, look, and perform their best regardless of age or injuries. Yes, this is the place where I answer your questions. I don't do it in the comments to videos. I don't do it in emails that get sent to me. I get hundreds and hundreds and hundreds of those every single week, and I just don't have time for it, but I do it here. So if you have a question, this is your chance. I am not giving specific medical advice, though, just in case you're wondering. I am giving information. I haven't examined you, I haven't looked at x-rays or MRIs or any of that. So what I'm doing, whether it's, you've gone to your doctor and he or she told you one thing and you don't understand that and want to talk about that, I'll give you my thoughts on that. If it's, hey, I did this and what are the possibilities, I will certainly share my thoughts, but I am not giving specific medical advice. Again, because one, it's not legal to do that in the United States across state lines or in other countries, but two, I haven't examined you, looked at x-rays or any of that. If you're watching on X, sometimes the comments on X come through, sometimes they don't. So if you are posting a question and not getting that, go over to YouTube. On my YouTube channel, you'll find this link. Again, if you're on YouTube, leave your questions in the chat, not in the comments below this video. I say this every month, and afterwards I'll go in there and there'll be 3, 4, 5, many, sometimes 10 or more questions left in the comments that I never got to see because I'm not on YouTube right now. I'm using a different software platform that's allowing me to send it to different places, and that's why I don't see those. So please leave those in the chat. If you're wondering how to do that, look for other people like Mike here, who says, hi, Mike. Figure out where that comment is and do the same thing. Travel poker, very cool. I'm not sure. There's probably more to that story. I would love to hear that. All right, we will start. Pitts 5839. What can you share about ultrasound? I can't. Like I said, I can't talk today. I don't know what is going on. About ultrasound guided fasciotomy for treatment of chronic exertional compartment syndrome. That is a good question. And let me back up a second. Pitts, just so everybody watching knows what we're talking about, because you're asking a fairly niche question, a very small part of the overall bigger thing with when you're talking chronic exertional compartment syndrome. First, what that is, it's typically the leg. Sometimes you can see it in the forearm in baseball pitchers, maybe softball pitchers. I've never seen it in a softball pitcher, but I have seen it in baseball pitchers. But it's typically the legs, typically in runners, sometimes in the military, where for whatever reason, the muscles expand with exertion, with running, but that those muscles can only expand to a certain extent because the muscles are broken up into compartments by fascia, thick connective tissue, and over time that swelling of the muscle gets to a point where it can't swell anymore, so something's got to give, puts pressure on the nerves and blood vessels traveling through the leg, causing pain, causes numbness and tingling sometimes. Over a long period of time can even cause things like muscle atrophy. Having said that, there aren't many non-surgical treatments that are terribly effective, and most people don't want to stop running in this case. There is some efforts to try Botox, but even Botox, typically a short-term solution, because eventually, again, that Botox is going to wear off, the muscles will continue to fire, so probably a short-term thing. So the treatment has historically been you make an incision in either one side of the leg or two sides of the leg, and you release the fascia. And typically, that's been a long enough incision or incisions to adequately release the fascia. Now, a lot of people don't want 6-inch or longer scars, but that the longer the incision, the more likely you are to release it. The biggest complication of that surgery is typically not releasing enough, and the symptoms don't fully go away. So what people have tried is, how can we make these incisions smaller to adequately release the fascia, but still, but not have a 6-8 inch incision on one or both sides of the leg, and they've done it through 2 smaller incisions. There's been different ways, and then some people say do ultrasound. Plus, the thought of ultrasound is you can visualize one of the nerves in the area and make sure you miss it. I will be perfectly honest, that sort of came about after I really came into favor, after I sort of transitioned away from surgery and into regenerative medicine. I would expect in the hands of somebody that does it well, the success rates would be good, especially for avoiding the superficial perineal nerve, which is the big risk. But is it adequately relieving the symptoms as well as the full open incision? And I'm not as familiar with that, but if the surgeon feels very good about doing that, I think that absolutely is a reasonable option. I know for everybody else that was a way long explanation, but getting at what he's talking about, that's what we're talking about. All right. Meg says, hi, it's good to see you, a frequent viewer of this. I very much appreciate you being here, Meg. All right, we got the beginning of a question, so I'll see if I've got that here later on. I don't know if I do. Travis, I've had I've had pain in my left ankle, radiates up the muscle in the front of my leg. Any idea what this could be contributed to? If I try to run, the muscle in the front of my leg hurts. All right, okay. So we may, I don't know, because this is one of those, I haven't seen you, examined you, but that is a little bit how chronic exertional compartment syndrome, what we were just talking about, happens. It's not so much ankle pain that radiates up, but you look at muscle pain potentially. Now, also some of the things you think about when you think of pain in the front of the leg, there isn't much there. There is a small muscle group, the anterior compartment, tibialis anterior, but there's also the bone, the shibius. God, it's one of those days. The shin, the tibia. So you're thinking shin splints, what we call periostitis medial tibial stress syndrome, which is an inflammation of the lining, the outer lining of that tibia bone. That would be one thing, something that usually can get better with some stretching exercises, short-term activity modification, sometimes anti-inflammatories. There's a physical therapy, a variety of ways to get over that, but it also could signify a stress fracture. So I guess the question gets to, for anybody dealing with leg pain, especially in running type athletes, is the pain getting worse? Meaning like in a run, used to bother you just when toward the end of a run, and it starts earlier and earlier and over the course of the run, and taking longer and longer to go away, and even to the point that it's starting to bother you with normal daily activities like walking. I think then it's worth sometimes getting x-rays or even more aggressive tests to make sure it's not a stress fracture. Stress fracture would be the worrisome one of the possibilities in that area. All right, McKenzie properties. Can low back pain be secondary to service-connected flat feet? Yeah, this is really more of a veteran question than this. Yeah, to be fair, this isn't really for the veterans work I do. I'm actually starting a live show for veterans, but reach out to me through my website, and the link in this description will get you there. Fill that form out, and that will get to a contact form, and you can contact me that way, and I can answer those questions. That's not really the purpose of this show, but I am starting a veteran show specifically for veterans for questions just like that, not on this YouTube channel, but on my other one. So great question. All right, back to the low back cortisone shots. Oh, that was the question from earlier. Spinal canal. Anyway, I've had cortisones 3 years in my cervical and lumbar areas. Recently told I have fatty buildup in my cervical channel. Have I heard of this? I have not, but I want to know the specific terms, because I probably have if I knew the technical terms they're talking about. I don't know if they're talking about some kind of vertebral lipoma or something like that. I wouldn't think that's anything bad, but again, without knowing the specifics, I'm not exactly sure. Pitt says, thank you, you are very welcome. I know I gave sort of a long answer, and everybody that doesn't have chronic exertional compartment syndrome is like, what in the world is he talking about? But if you have had it, it is annoying. And I think I had, back when I was a runner a long time ago, I had like the precursors to it, but then about the time I started residency, I sort of cut back on running a lot, and it never really became an issue. But my patients that have it, it's one of those diagnoses that doesn't go away very often, and it can be really aggravating. All right, Price says, following a labral repair July 2021, seems like my tricep tendons have fallen apart. Tricep tendonitis plagues me. Curious if the length of time I was inactive triggered it. 25 plus years of lifting. That stinks. As somebody that lifts weights pretty much every day, I would be miserable if I couldn't do that. I can't say that I have heard that. The biceps and triceps do come off the shoulder and in that area, so that I guess isn't that surprising, but I can't say I've seen that as a relation to some of the surgery. You do wonder, because most labral repairs, where you put stitches and anchors, reattach the labrum, tighten the capsule sometimes, involve immobilization and then a long period of time before you're doing stuff full range of motion, and especially full strength. So a lot of times what can happen is you get muscle atrophy that can be very difficult to overcome, and could lead to a tendonitis type of situation as you get back into heavier activities. Without, again, knowing more, I think there's two things. One, really aggressive physical therapy specifically for this triceps problem. And then two, if it isn't turning the corner, find out what's going on, i.e. probably getting an MRI to look at that triceps tendon, see if there's degeneration of a small area of the tendon. A tendinopathy or tendinosis type of thing is typically what that makes me think. What do you do if you think your ACL in your knee? I'm assuming that the answer to that, or to the missing word in there, is injured or torn or something like that. I and Meg, please tell me if that's not your question. I would want to know, and that's twofold, and one before the other typically. Go see somebody that's what they do, an orthopedic surgeon that specializes in sports medicine. That's generally a fairly straightforward physical exam set of tests that can tell you that. Other than maybe in the 7 or so days sort of right after the injury where the knee is big and swollen after a torn ACL, where it can be hard to get a good exam, any other time somebody that does this a lot can be reasonably confident that that's an ACL tear even without an MRI. Sometimes though, and we've gotten to where we order more and more MRIs for ACLs than we used to, because a lot, for any other reason, one, to confirm the diagnosis, but two, to make sure there's no other pathology that might change how it's addressed. Meniscus tear that needs to be repaired, MCL, other ligaments like the PCL, LCL, posterolateral corner, that kind of thing. So those would be the two steps if that's what you're asking. Mike, another VA question. Probably, again, if you don't mind, and again, this is just a different purpose of this show, go to the link in the website below, contact me that way, and I can answer any veteran and disability claim questions. Gabrielle, just started running, noticed my ankles getting sore and stiff, staying that way. I don't know what the question there is. Ankles getting sore and stiff and staying that way. She says, I love the channel. I very much appreciate hearing that. It's hard to know just based on sore and stiff because there's so many issues around the ankle, be it little things, just sort of wear and tear, early arthritis, stress reactions, stress leading up to stress fractures. It can be soft tissue impingement. It can be any number of things. So I don't really want to speculate on that. A lot of times, rather, if you don't want to go straight to an orthopedic surgeon, sometimes one visit or a series of visits with a physical therapist can kind of not just get you better, but also identify simple things that can get it, that it could be, and if it's something worse, they could send it on. Price says, thank you, PT's being scheduled next. Yeah, keep me informed, but I think that's a great start. She goes on, Gabrielle does, is it safe to bench 2 years after ORIF? Certain heavy objects cause pain with lifting. So that's a good question. I generally don't restrict people from physical activities much at all, certainly not 2 years later, assuming a fracture healed. So yes, and not just lifting weights, running, anything like that. If it's painful, a lot of times with lifting weights, what can be helpful is to do what are called closed chain exercises, meaning your foot's fixed on the floor rather than open chain, or impact where you're landing from a jump, plyometrics, box jumps, things like that. So squats, lunges, things like that might be a little bit easier, but generally, no, I don't have a huge issue with that. It may cause pain, but I suspect that a patient wouldn't necessarily be doing damage to that area. 2 years later, you would think that fracture's healed. Now, it does get to the question, if there's hardware still in there, and if the hardware is irritating, could you make a case to remove that hardware? That's a whole other discussion, but sometimes there can be a good use for doing that. Meg says, thank you, you're very welcome. Should you lift accordingly? That's sort of what I was getting at. Alexander, tennis elbow for 2 years. I've tried all the exercises, nothing helps. 2 cortisone injections in my elbow, dissolves the ligament. Yeah, so I am really, really, really not a fan of steroid injections for tennis elbow. The studies are very clear. So many studies that have shown it has inferior outcomes. Not even in terms of short-term pain relief do the steroid injections help much. They're worse than basically doing nothing. They're worse than PRP, certainly worse than just physical therapy. Maybe you could you couldn't talk me into it anymore, but most surgeons, you probably can talk into doing it once. I feel though that the risk you run is more likely to come back and lower outcomes overall. So I would try to avoid it and try any number of other things. And if you don't want to go down the regenerative rabbit hole, at least aggressive physical therapy. They've got a number of Graston techniques and things that might be helpful in the regenerative world. There are peptides, there's penicillin polysulfate, there's PRP injections, there's stem cells, there's exosomes, there's all sorts of things. Other thing, maybe getting an MRI to look at the status of the tendon and make sure there's not actually a small tear there, especially in the setting of cortisone shots. But even if you haven't had one, those are all sort of things that think about. Just quick cortisone shot. And we can blame the surgeons all we want. There's definitely blame to be had here, but so many patients just want the quick fix and want the steroid shot, and then get sort of frustrated 6 weeks, 6 months later when it comes back, and now it's even worse and it's even less likely to heal. So I'm a big believer, and the science supports that, of really avoiding cortisone shots for tennis elbow. Yeah, and I apologize, Mike. It's just 2 different shows, but May 5th, after I do this show on my Veteran Nexus Letters channel, I'm starting a live show just like this. So you'll hear about that soon if you contact me. Gabrielle says, I'm also flat-footed. She's got a lot going on against her. Flat feet, I will tell you, this gets to, ironically, military, but really a lot of people. In and of itself, flat feet don't predispose you like you're going to 100% get anything, but in the setting of either overuse or a specific injury, it could be yet another thing that sort of increases the chance of developing a condition down the road. So in Gabrielle's case, it probably didn't cause the fracture, but maybe it's contributing to some of the issues that she has now. But again, you can have high arches, fixed arches, pes cavus, and also have issues. You can have normal feet and develop issues after ankle fractures, but it is interesting. Meg says, had surgery on my foot 10 months ago. Jeez, can't read today either. 10 months ago, did physical therapy, still experiencing a lot of pain. Yeah, Meg, let me know the type of foot surgery. It's hard to comment on that specifically. Gabrielle says the hardware is still in. Without knowing, I will say, as somebody, I didn't do as much in the way of foot surgery as the foot and ankle orthopedic surgeons. I got a lot of foot patients. As sports medicine, you get a lot of athletes, but the surgeries, I mean, in sports medicine, you're probably limited as far as the surgeries you do to ankle arthroscopies, maybe base of the fifth metatarsal. That's a pretty common sports medicine foot surgery. Maybe the occasional Liz Frank surgery, but the more reconstructions and that kind of thing typically go to the foot and ankle orthopedic surgeons, the hallux valgus, any number of things. And so sometimes that might be a better question for them. But I will say that foot surgeries are notoriously hard, just as a general category, notoriously hard to get over, just because there's so much weight bearing and everything you do involves weight bearing. And so that is sort of the nature of it. It's one of the reasons I wasn't really super excited to do foot and ankle orthopedic surgery as a subspecialty, as like my career, because a lot of them, they struggle getting over a lot of these. She says, had bunion surgery, do have hardware in it. Yeah, bunion, again, it depends on the type of the osteotomy and things like that, but can be tough to get over. Let's see, Alexander, about tennis elbow, not cortisone, then what can help? What specialist? I'd probably say sports medicine, orthopedic sports medicine as far as a specialist, or orthopedic shoulder and elbow if you're at a big academic center. But most practices don't have that. Just sports medicine would be what I'd look for. As far as the things, it's what I was talking about earlier. It depends on where you are in that process and what type of practice. So the traditional orthopedic surgeons are going to have things like platelet-rich plasma, and steroids, honestly, and sending you to physical therapy. In kind of what I do in the regenerative medicine world, you also have access to, like I said, exosomes or stem cells. You have access to peptides, things like shockwave therapy that traditional orthopedic surgery doesn't typically have, but it's because for insurance reasons and any number of other things. Gabrielle, displaced midshaft fracture to the radius. I am curious. I'm not 100% sure. Yeah, not 100% sure. Anyway, that looks like it is it. Very, very excited. Thank you so much for joining. If any questions rolled into the comments, I'll try to grab those and maybe answer those at the beginning of the next show, which will be Monday, May 5th at 5 p.m. Also, those of you who watch this as veterans, I know there are at least 2 of you asked questions. That live show also starts Monday, May 5th at 5:30 on my Veteran Nexus Letters live or Veteran Nexus Letters channel. So that will come soon. I am very, very appreciative of you being here. Very much enjoy these. Thank you for joining me. Watch all the future videos coming later this month, and I will see you here again next month.